Hi, I'm Andrew Schmidt. I'm an instructor with Surfing Medicine International from the US, and I'm going to do a very quick review on immersion hypothermia, specific to the pre-hospital phase. Now, it's important to understand that thermoneutrality in water is around 33 to 35 C. So what that means is that any person in water that we'd usually surf or recreate in is actually losing heat to the ambient environment and therefore at risk for hypothermia. Now, significant risk of hypothermia is in water less than 25 C. There are multiple ways to lose heat to the ambient environment. First off is radiation. In air less than 35 C, this is where 60% of our heat loss is. And again, this is just heat radiating off the skin to the surrounding air or water. Next is conduction. So this is transfer of heat between any touching surfaces, and water counts as a surface. So when your body is immersed in water, it is conducting heat from the skin to the water. Now, the next method is convection. So just like a convection oven works by drawing hot air across food, any air or liquid medium that draws across the body is going to transfer heat between the body and that medium. And then finally is evaporation. So essentially this is why the body sweats or perspires, is to cause liquid to hold onto the surface of the skin and then evaporate off and transfer heat. Now, a lot of our treatment is going to be based on the severity of hypothermia. There are a couple different ways to stage it. First off is the traditional staging, and this is based solely on temperature. So anything below 35 but higher than 32 is mild, anything between 28 and 32 is moderate, and anything 28 and below is considered severe hypothermia. Now in the field and even in the hospital, we often don't have accurate temperature measurement. So probably a more useful and practical method is the Swiss staging. And this is based more on clinical symptoms. It also involves temperature. But you can see that it depends on consciousness, shivering, and also the absence or presence of vital signs. So physiologically, what actually happens when we're cold? Well, neurologically, with mild hypothermia, we start getting impaired judgment. Now, this is an issue because you're in a dangerous situation and now you're not making good decisions. With moderate hypothermia, we start getting decreased consciousness, and with severe hypothermia, you're at risk of going unconscious. Now, cardiovascularly, initially we can get tachycardia. This is due to the initial cold shock response. But as that hypothermia prolongs, we start going into expected bradycardia. And then with severe hypothermia, we're at risk of dysrhythmia due to a cold myocardium. Now, this dysrhythmias can be a number of things. It can be AFib, it could be ventricular fibrillation, it could be some AV blocks. Classically, it's what's called the Osborne J waves. And this is an up-notching that follows your QRS, and this is pathognomonic on ECGs for severe hypothermia. The pulmonary system, just like cardiovascular system, initially we get tachypnea. So you have that initial cold shock response, you start breathing faster. As your hypothermia prolongs, it gets worsened, we get bradypnea and eventually apnea. As for some other physiologic responses, initially with mild hypothermia, we can get hypertension. That's from that initial cold shock response. But as we get colder and sicker, we can get hypotension in a shock state. Initially, mild hypothermia, you also get shivering. That's your body's innate response to try to warm itself. But as you get colder and sicker, that shivering stops. You're no longer able to warm yourself up. You can also get muscle rigidity, which is going to affect your fine motor skills and ability to save yourself. Now, it's important to have insight into what happens with your initial cold water immersion, not only so you can expect it if you fall into cold water, but also to teach others so that they can expect it. If you know what to expect, you can kind of increase your chances of survival and rescue. The initial phase is called the cold shock response, and that can last up to 2 minutes, and it varies. But initially, as you can imagine, when you get in that cold water, you're going to have an initial gasp, and then you start hyperventilating. Like I said before, you get tachycardia, you get hypertension. So you actually have an increased cardiac workload. So patients who are higher risk cardiovascularly can actually have some bad outcomes just from this initial phase. Now, we always think of people dying from hypothermia from prolonged exposure, but in this first phase, you actually have a very high risk of drowning. This is the phase that people panic in. And if they aren't ready for the situation or are not a good swimmer, they can actually submerge in this first 2 minutes and die from drowning initially. Now, if you survive that initial cold shock response, the next phase is cold incapacitation, and this can last about 15 minutes or so. And this is when you start getting muscle stiffness and cramping, and also decreased fine motor skills. You can imagine this being a problem because this is a phase where you want to start making life-saving maneuvers and making a plan for saving yourself. So you have a kind of a small window of time where you can actually do these maneuvers appropriately and efficiently. And the next 30 to 60 minutes is when we start going into moderate to severe hypothermia. So we've gone through our initial cold shock response. We started losing our fine motor skills, started getting muscle rigidity, and now we are getting the true core cooling that is going to affect the rest of our physiology. Now, we like to think all the danger is in that phase where you're in the water and getting cold, but there is also the chance of morbidity and mortality with rescue. There's what's called circumrescue collapse. So a couple different reasons for this. You can get syncope and arrest at the time of rescue. And the reasons they think this may happen is first off, when you take a patient into a vertical position, maybe lifting him up in a boat, you're now going to get a drop in blood pressure. And that could affect the heart and the nervous system as well. You also get a drop in catecholamine release. So you have been freaking out this whole time trying to get rescued. Now you see someone coming to help you, and suddenly you kind of let your guard down. The catecholamines go down, and you may actually have a drop in blood pressure because of that. And thirdly, like I said before, you have a cold myocardium. So shifting these patients or bringing them up on a boat or doing some other maneuvers can actually overstimulate that myocardium and cause dysrhythmias. So what are our goals of resuscitation for these patients? Like any other resuscitation situation, we first focus on the ABCs. Now, ABCs for hypothermic patients are a little bit different. We like to focus more on signs of life. So not so much just breathing and circulation, because in a very cold patient, it can be hard to feel a pulse and it can be hard to monitor respirations, especially if you're only checking for 10 seconds or so. If someone's breathing 4 to 6 times a minute, you may not see it. If someone's pulse is only 30 or 40, you may not feel it very well. So you actually want to look at the whole picture. Can you visualize the patient breathing? Are they moving? If you have advanced equipment, do they have good end tidal? Do they have cardiac rhythm on monitor? Do they have cardiac squeeze on echo? But if you're checking your basic ABCs, you need to check them for around 30 to 60 seconds to make sure you actually capture anything that may be there. And the reason for this is we don't want to do CPR on a patient who's severely cold if we don't have to. Because again, that cold myocardium is at a high risk for dysrhythmias. Now, if we do determine that the patient needs CPR, we're going to do CPR in the normal manner that we do. We're not going to try and match our respirations or compressions with what we expect for a hypothermic patient. We're going to follow the normal ratios and algorithms that you follow by your national guidelines. Now, when it comes to ACLS, it's not as clear. Lots of different countries recommend different things in their guidelines, and what that shows us is that the evidence just isn't clear. But in general, most places agree that there should be some modified form of ACLS. When we're above 35 degrees C core temperature, we do our normal med intervals and normal defibrillation guidelines. As we drop between 30 and 35 C, we want to double our medication intervals. The reason for this is we don't want to build up too much volume of medication because it metabolizes slowly. Because once the patient gets RUSC, they could then have toxic level medications within their system. But follow normal defibrillation guidelines. Below 30 C, it's best to withhold vasoactive medications and try for a single defibrillation attempt. Your goals of resuscitation at this point are going to be rewarm the patient. Now we can rewarm really by any means that we have available. There are active and passive forms of rewarming. But again, use sleeping bags, use board bags, use blankets, use body-to-body contact, really anything available. But most importantly is to get the patient out of the environment. That's going to be step one for rewarming. You can take a stepwise approach to rewarming based on the patient condition. It's obviously going to be dependent on what resources you have. If we're in mild hypothermia, you can focus just on passive rewarming, so getting the patient out of the environment, putting them on blankets, getting them out of wet clothes. Once you get to moderate, we can start thinking of active rewarming, external and internal. So externally, we're going to use things like bear hugger or forced air rewarmers. Active internal, you can use warm fluids, you can use warm humidified air, you can use warming devices intravascularly. And then the most severe forms, depending on your resources available, ECMO is going to be your best bet. Now, we've all heard the mantra, you're not dead until you're warm and dead, but that's not actually true. Some people are cold and dead and will never be warm again. There are some reasons to actually cease efforts or to not start efforts at all when it comes to hypothermic patients. These include if the patient's frozen solid, if there's ice occluding the mouth and nose, if their core temperature is less than 10 C, and the big reason for this is there's just never been a study showing someone survive a temperature lower than that. Known submersion greater than 1 hour. That will be different for very small children who fall into icy water because they do actually have a little higher chance of survival. There are some cases of survival in this. but stick with your local protocols and obvious lethal injury, so decapitation, lividity, stuff like that. So what do we do with these patients? We've rescued them, we've done our initial resuscitation. We can kind of step back again to our stepwise approach based on the clinical situation. Obviously, all of this is going to take into account your local resources, where you may be located, the safety of enacting a rescue. But our mild hypothermic patients, we initially treat them with our passive techniques. If there's no improvement within 30 minutes or so, we may want to go ahead and transport them to a medical center if it is available. For our moderate hypothermia, if it is safe and feasible, we want to go ahead and plan for evacuation early on. Evacuate carefully with our moderate and severe patients. Again, they are a higher risk for dysrhythmia. So when we're extricating from the water and moving to a truck or ambulance or helicopter, whatever it may be, we want to be very gentle with these patients and not make any large motions with them. And then with our severe patients, again, evacuating as soon as possible. It's preferred to go to advanced center, whether that be by air or ground, depending on your local resources and, again, safety and feasibility. Ideally, in many countries, there are protocols in place to specifically take these patients to ECMO centers. So wherever you may be treating patients or wherever you may be surfing, it's good to understand kind of what the local environment is. So we'll wrap up with self-rescue. Obviously, this is important for all of us to know in case we find ourselves in a bad situation, and also good information for you to pass on to those who you might be teaching. Now, a lot of this isn't really hard science, but there is expert agreement that we should keep something like the 1-10-1 rule in mind, if nothing else, because it's kind of easy to remember and will give you a stepwise approach to improve your chances of survival if you should find yourself immersed in cold water. Now, the first one of the 1-10-1 rule says you have 1 minute to get your breathing under control and to kind of bring yourself a sense of calm and avoid panic. Like I said, panic increases your chances of drowning. So you want to get your bearings. You want to kind of understand what situation is going on. Tell yourself that, okay, I've survived this first initial part. Now I need to start thinking of the next step to improve my survival. Now, next you have about 10 minutes of meaningful movement. So after this time, that's when you start losing your fine motor skills. That's when your cognition might be impaired. So you want to complete any life-saving task, whether that put a flotation device on or find a stable object to latch yourself to or to hold on to. Also, ideally, you want to remove yourself from the water. The best place to be in this situation is actually out of the water. So depending on if you have a board, if you have a boat or some other craft, or just getting your bearings and trying to find out where the closest stable surface or land may be. And then finally, you have knowledge that you may only have about an hour of consciousness. So again, ensuring any life-saving measures, calling for help if you have a device, finding the closest land or craft, trying to get yourself out of the water, and prepare that if you're out there longer than an hour, you may actually slip into unconsciousness. But setting yourself up for success and setting yourself up for being found. Now, while you're in the water, you need to conserve heat as best as possible. Like I said, the best way to do this is actually remove yourself from the water. That's going to decrease your conduction from the water. So this picture is actually of a person who was involved in a boating accident in Florida where there are other boaters on board, and he was the only one survived. And they think the reason he was is because the other one stayed in the water and tried to swim, and he actually climbed up on top of the boat and was found by a helicopter and was able to survive because he didn't have as much heat loss or fatigue as the other people. There are also some other theoretical maneuvers you can do. They don't have great evidence, but there are some techniques like the huddle position or the knee to chest position. All this is kind of dependent on having a flotation device on, but what it can do is conserve heat in the core. It can also build mental morale, which is important. When you have the group of other people with you, you can kind of keep each other in check and also improve the chances that the whole group is found instead of just one person. Okay, now I've self-rescued. I've tried to improve my chances of rescue and survival. So what do I do? Do I stay put? Do I go try to find land? This isn't really evidence-based, but there is some expert consensus to at least help guide your decision-making in this situation. Now, probably the two most important things to guide this decision are, do you have a flotation device either on or nearby, and do you know if rescue is en route? So if you have a flotation device on and you know that rescue is en route, it's a good idea to stay where you are because since rescue's en route, probably someone knows where you are because that means they know that your boat or other craft went down or helicopter went down. And so they're going to be coming to that location. So you want to go ahead and stay put, especially if you have a life vest or a PFD or some other flotation device on. Now, if you have a flotation device but rescue is not en route, then you need to estimate your time to swim to safety. This is obviously going to be difficult if you're out in the middle of the ocean, but if you know where land is and you think it may be greater than 45 minutes to swim, you want to go ahead and stay. Again, knowing that you are only going to have at most an hour of good physical conditioning, you hope that someone might know that you're gone and come out to find you. If there's less than 45 minutes estimated time to safety, then you may want to go ahead and start swimming. Obviously, this is dependent on your swimming ability and what flotation device you have, but the sooner you make this decision, the better. Now, if you don't have a life vest or PFD on, but there is a buoyant object like that boat or like a surfboard, you want to go ahead and stay with that object. Again, this is especially in the case that it may be 30, 40 minutes until you get to land. You want to be with the floating object that you can ideally be out of the water because that's going to increases your chances of survival. Now, if you're in the unfortunate case that you have no flotation device and nothing to latch onto or to float with, you're just going to have to swim. That's the unfortunate truth. I hope this quick review of immersion hypothermia helped you gain some insight into the physiology of hypothermia, the initial treatment and resuscitation, but most importantly, how to keep yourself safe and how to teach others to be safe. Please contact us at Surfing Medicine International if you have any other questions.